Oh goodness, well, it's quite a long time ago now, but I always used to describe it as social work with a bit more razzmatazz. So it's engaged with local people, with local communities, engaging with the things that change their lives, but recognizing that you can do a lot locally, engaging with people, but the context within which you're working is determined by political choices, both national and international. So I was interested in those choices and that created the context. One of the beauties of our political system is that you remain engaged with local communities because you are an elected member for a constituency, but at the same time, as the elected member, you're able to take part in shaping the context through the national political choices. Well, I was twice a health minister, once as a junior minister when Ken Clarke was Secretary of State, and then I went back a few years later as Secretary of State. And it was a time of great change in the health service because although it's since unfortunately become a habit to change the legal structure of the health service every few years, I think we've got into a habit, as I say, of pulling up the plant to see whether the roots are growing. In what we did in 1990 was to introduce for the first time the idea that there are two separate functions being carried on within the National Health Service. One is making choices on behalf of the taxpayer about how public money is spent within the health service, and the other is the management of the delivery of healthcare, and they are two separate functions. Which the NHS Confederation is it's a membership organisation of membership organisations. That's how we're developing the Confederation, so that it speaks on behalf of its members. Clinical commissioners speak on behalf of the point of view of the clinical commissioner. We're encouraging, we're in conversation with the National Association of Primary Care to bring them into full membership, full participation within the Confederation on behalf of the voice of primary care. And we also have an evolving relationship with, for example, the Local Government Association, because you can't do healthcare without engaging with social care and social housing, which are local government responsibilities, not NHS responsibilities. So I see the NHS Confederation as an organisation which is committed to the joined up relationships which need to exist if we're to deliver both efficient use of taxpayer resource, but more importantly, effective achievement of health objectives within. Well, the person who was the original advocate of Devo Mank, or one of the key advocates, I think there's a danger of over-personalising this, but I do think it's true that the principal architect of Devo Mank was Sir Howard Bernstein, who's the chief exec of Manchester City Council. And he, of course, has recently announced that he's going to be leaving the post next year. I think I've described him as the new Beveridge, as somebody who's rethought what public services should mean in the service of local communities, to an extent that the process he led has been a game changer, and I think it's being followed through now in other localities. And I think it's worth reflecting for a second on the way that Sir Howard always presents this case. He doesn't talk about it as public service reform. He says that what he's been involved in Manchester is rethinking local government in a way that starts by saying what we're seeking to do is to create sustainable communities. These are communities that people want to live in. People have fulfilling jobs. They have attractive living communities. They have attractive public spaces. That's as much part of the objective of greater devolution to local government as the more operational issues of joining up different silos within the health and care system. That's a consequence, it's not the driver. As to the question of whether the devolution agenda has a direct effect on primary care, I think the answer to that is yes, that it does, because as you think through place-based services, to use the current jargon, that's to say public services which are designed across the traditional silos to focus on the needs of citizens and communities, you will increasingly be challenged to justify, for example, the distinction between primary care and community health services, which only exists because of a political decision or a political deal done by Nair and Bevan with the BMA in 1946. How much longer do we have to live with silos that were created on the basis of a political fix? We have a silo between community health and primary health. We have, in truth, silos within primary health between, for example, pharmacists and GPs. And we have silos, a further silo between primary health and community and social care. So joining those services up so that as a citizen I receive support to enable me to lead a life that is as healthy and rewarding as possible, that's the challenge to which the devolution agenda is addressed. Yes is the short answer to that. I think that, first of all, the previous government before the change of Prime Minister, and I think that this will continue, I understand this is their intention to continue with a programme of combined authorities, increased devolution, encouraging local communities to step forward to rethink the way that public services and local government, actually it isn't just about public services, it's about local government developing its role within a local community. That continues to be a direction of travel, and not just in this country actually, I think there's an increasing recognition that thinking of public services as national silos is a way of reducing their effectiveness in the service of citizens, and they need to be joined up and they need to be built around the needs of local communities. So that's happening at the strategic level in different ways in different places, but I think that the direction of travel is reasonably consistent. And if you're doing that across the range of public services, the idea that you do it across all public services except health just seems to me to be so absurd that even to state it is to demonstrate that it's nonsense. I mean, I think the objective set out in the NHS planning guidance is actually the right objective, which is to develop a system-wide view. The Health Service has argued for a long time for the need for a system-wide view, and I think that's right. It's also argued for the need for joining up health and social care, and I would say a broader range of public services, and that you can't do without engaging with the people that hold that statutory responsibility, in other words, the local authorities. So the objectives set out in the STP process are the right objectives, in my view. I also think that we're starting to get to grips with, and I choose my words reasonably carefully, the need to be seen to be doing that in a publicly accountable way, and drawing a distinction between the inevitable private conversations that go on as you think about options and the decision-making process about the use of public money, which should happen in public with proper accountability and proper visibility. All of that is good news. What's less good news is that this is being done on an unrealistic timescale without sufficient clarity. And I think that I don't think anyone involved in the STP process would regard it as having been anywhere near perfect. But the objective of a system-wide view, including local government in the choices about the use of public resources, those seem to me to be the right objectives. Well, I've already mentioned the STPs and the role they play in joining the health service back into the range of local public services. And there are 44 STPs, of which only 4 are led from the local authority side of the fence, Birmingham and Solihull being one of them. And that was part of the reason that I was attracted when I was asked to go and do the job in Birmingham and Solihull, that I do think it's important that we look beyond the traditional silos of the secondary, tertiary care, primary care, social housing, and look at the health service in the context, as I have already said, of being one of a range of public services delivering a set of objectives to a community. And one of the issues that primary care is having to deal with is that because services haven't been more properly joined up, because there aren't proper links between housing, social care, NHS primary care, NHS community care, we've not taken opportunities to engage to support people in their local communities. And they've tended to present themselves either in GP surgeries or in A&E departments or in admission wards with conditions that are avoidable. Now, the National Audit Office did some work some years ago looking at bed occupancy in NHS hospitals and concluded that roughly a third of NHS beds at any one time are occupied by people who, if we'd taken the opportunity to support them properly, wouldn't be there. If that's true in hospitals, the same thing is true, and any GP will tell you this, in their surgery attendances, that if there was proper support for home care services, if there was proper support through the housing department, that would have an effect. I'm not saying it resolves the issue, but it would undoubtedly have an effect on attendances in GP surgeries. So there's an important point here. If you look at the pattern of public expenditure across the range of public services, we cut spending on housing, we cut spending in particular on social care, we channel NHS resources towards secondary care, not towards primary care, and then we wonder why people are ill when they don't need to be.